Good afternoon. Today's class we will be talking about antibiotics, or also called antimicrobial agents. At the end of this session, you will be able to define what an antibiotic is, what is chemotherapy, what is an antimicrobial agent, what are the different sources from which antibiotics are obtained, and briefly about the mechanism of action of antibiotics and their sites of actions. We will also be touching upon combined use of antimicrobial agents. Coming to the general consideration of antimicrobial agents. Definition of antibiotic. Antibiotics are substances produced by microorganisms that kill or inhibit the growth of other microorganisms at high dilutions, that is in low concentration. So antibiotics are natural in origin. They are produced by microorganisms and they inhibit or kill other microorganisms at low concentrations. The term chemotherapy refers to the treatment of infections, infestations or cancer with drugs. So chemotherapy means use of chemicals to treat infections, infestations and cancer. Antimicrobial agent is a synthetic substance that kills or inhibits the growth of other microorganisms at high dilutions or low concentrations. As of today, the terms antibiotic and antimicrobial agent are interchangeably used. A very brief history about how we have progressed so far with the antimicrobial agents. In India, for more than 2000-3000 years earlier, the oil from this plant called chal mugra was used for the treatment of leprosy. In China, moldy or spoiled curds was used for the treatment of skin boils. Aztec Indians, that is the native tribes of South America, used the plant Chenopodium for treating intestinal worms. In the 16th century, in Europe, mercury was used or introduced for the treatment of syphilis. In the 17th century, another plant bark, cinchona bark, was used for the treatment of fever. The German immunologist, pharmacologist, microbiologist named Paul Ehrlich is called the father of chemotherapy. This is a usual question in the Viva. Who is called the father of chemotherapy? It is the German pharmacologist Paul Ehrlich. This picture shows Ehrlich with his Japanese assistant Shiga, after whom Shigella is named. Paul Ehrlich actually coined the term magic bullets, referring to chemicals which will be active only against microorganisms without harming or injuring the host. This is a picture of Sir Alexander Fleming, who discovered the first known antibiotic, namely penicillin. The German chemist pharmacologist Domark in 1935 synthesized and used for the first time a sulfonamide dye which was used in the textile industry. In fact, he treated his own daughter for gram-positive cocci infection. So, Prontosil, a sulfonamide, was the first antimicrobial agent used because it is a synthetic substance, whereas penicillin, being natural, is the first antibiotic which was used. So in 1928, Fleming discovered penicillin, but by the time it came to be used in human beings, it was almost another 7 to 8 years. Selman Abraham Waxman, who was awarded the Nobel Prize in 1952, coined the term antibiotic, meaning, like we defined earlier, substances produced by microorganisms that kill or inhibit or retard the growth of other microorganisms at low concentrations. Waxman discovered the antitubercular drug streptomycin. Now this diagram depicts the different sites of actions of antimicrobial agents or antibiotics. For example, starting with the outermost layer of the bacteria, namely the cell wall, we have quite a few antibiotics which act by inhibiting cell wall synthesis in susceptible bacteria like the penicillins, which come under the beta-lactam group, ethambutol, bacitracin, etc. Now moving to the next level, that is at the level of DNA synthesis. DNA replication is inhibited by the quinolone group of antibiotics and metronidazole. Interfering with RNA synthesis are rifampin, also called rifampicin, and rifabutin. The antimetabolites, namely sulfonamides, dapsone, and trimethoprim, they interfere with folate synthesis in the bacteria. Interfering at the ribosomal level, that is where protein synthesis takes place, acting on the 30S bacterial ribosome, include aminoglycosides and tetracyclines, whereas chloramphenicol and the macrolide antibiotics inhibit bacterial protein synthesis at the 50S ribosomal subunit level. Now coming to some definitions, we have already defined antibiotic, antimicrobial agent and chemotherapy. When one says spectrum of activity of an antibiotic, it refers to the different microbes against which an antimicrobial agent is effective. So based on the spectrum of activity, we can group the antibiotics into narrow spectrum and broad spectrum. The term bacteriostatic means the antimicrobial agent or antibiotic inhibits the growth of bacteria. Bacteriostatic retards bacterial growth, whereas a bactericidal drug kills the bacteria. Cidal meaning to kill. Most of the bactericidal agents are effective against rapidly multiplying bacteria. So what happens if a static and a cidal drug is given together? The cidal drug will inhibit bacterial growth, which means, the bacteriostatic drug retards bacterial growth. Whereas for a cidal drug to be active, the bacteria need to be rapidly multiplying. So if a static and a cidal drug are given together, the cidal drug will not act. The term minimum inhibitory concentration refers to the lowest concentration of the antibiotic which is capable of inhibiting growth of a microorganism in a defined growth medium. Now what do we mean by this defined growth medium? For example, the Mycobacterium tuberculosis grows in Lowenstein-Jensen medium. So if I want to test the minimum or evaluate the minimum inhibitory concentration of an antimycobacterial drug, the Mycobacterium tuberculosis has to be grown in that specified medium. Another definition here is superinfection, also called suprainfection or opportunistic infection. Commensals are microorganisms which are normally present in a host. They do not cause any disease under normal conditions. But these commensals can become disease causing if the microflora of the oral cavity or the gastrointestinal tract is altered by an antimicrobial agent. Now imagine if there are 5 commensals, they are actually competing with each other, so they do not allow any one species to flourish. If an antibiotic kills 3 of these, then the other 2 have less competition, they grow and they can cause a disease. So the antimicrobials or antibiotics cause superinfection by altering the microflora. Whereas corticosteroids and immunosuppressants result in superinfections by suppressing host immunity, because corticosteroids are also powerful immunosuppressants. So for a 3-mark question on superinfection, one needs to define what is a superinfection and include antimicrobials which alter the microflora, corticosteroids and immunosuppressants which suppress host immunity. Examples of superinfection include pseudomembranous colitis and candidiasis. Bacterial resistance has emerged as a major problem. What do we mean by bacterial resistance? It means the antibiotic is no longer effective against a particular microorganism. Resistance to an antimicrobial by the bacteria can be either natural. For example, certain strains of species of Staphylococci are resistant to the actions of penicillins. More important is acquired resistance. Acquired resistance is a result of improper or irrational use of antimicrobial agents. There are different mechanisms by which resistance to antibiotics develop. For example, penicillin is chemically called a beta-lactam. Some of the resistant strains of bacteria, that is bacteria which have become resistant to penicillin, do so by producing an enzyme which breaks down penicillin. So once penicillin ring structure is broken down, it can no longer act. Another mechanism by which a bacteria becomes resistant to an antibiotic is, for example, erythromycin has to bind to the 50S ribosomal subunit of a bacteria. In resistant bacteria, what happens is the structure of the 50S ribosomal subunit is altered. So erythromycin is no longer able to bind to that altered 50S ribosomal subunit, and therefore the bacteria has now become resistant to erythromycin. Another example of altered binding site is methicillin resistant Staphylococcus aureus. What has happened is penicillin needs to bind to a protein called penicillin binding protein. In MRSA, the structure of the penicillin binding protein is changed, so penicillin is no longer able to bind to it and therefore is ineffective against MRSA. A third mechanism of drug resistance is, for example, tetracyclines. Tetracyclines need to bind to the 13S ribosomal subunit of the bacteria, which means tetracycline needs to enter the bacteria. In resistant bacteria, the uptake of tetracycline is reduced. So tetracycline does not enter the bacteria, therefore is ineffective. The fourth mechanism by which resistance is seen is, example, this enzyme DNA gyrase, which brings about the uncoiling of the DNA helix. That is the site of action of the quinolone antibiotics. In resistant strains, the enzyme structure is altered in such a way that the quinolone is no longer able to bind to the enzyme. A fifth mechanism by which bacteria or parasites, protozoa become resistant is once the drug enters the microorganism actively throws out the drug. Example, in chloroquine resistant plasmodia, that is the parasite which causes malaria. R factor is usually a 3-mark question in microbiology. So what is this R factor? R factors are plasmids which carry the resistance gene, and it is a major mechanism of transfer of resistance between bacteria. You would have read in microbiology, what are plasmids? Plasmids are extra chromosomal genetic material which can get incorporated into the bacterial chromosome. One of the methods by which the chances of resistance developing can be reduced is to use multi-drug therapy, using the right antibiotic for the right duration and using the right dose. These are terms which you generally learn in bacteriology. What is mutation, conjugation, transformation and transduction. Now we have some situations in clinical practice where more than one antibiotic has to be given to a patient. This is called combined use of antimicrobials and is usually a 5-mark question in your exams. Now what are the objectives of using a combination of antibiotics? The objectives include drug synergism, that is the use of one or more drugs when the effect is more than additive. For example, sulfonamide is an antimicrobial agent which is bacteriostatic. Trimethoprim is an antimicrobial which is bacteriostatic. When the combination is used, it becomes bactericidal. This is an example of drug synergism. Or beta-lactam like penicillin plus an aminoglycoside like gentamicin. Both these are bactericidal drugs. Second objective is to reduce the individual toxicities. When more than one antibiotic is used, the dose required is usually reduced. Therefore, the individual toxicity is also reduced. Example, multi-drug therapy in the treatment of tuberculosis. By targeting different sites for action of the antimicrobial, the chances of resistance developing is reduced. Then to broaden the spectrum of activity, like we said, narrow spectrum antibiotic, broad spectrum antibiotic, effective against gram-positive, effective against gram-negative, effective against aerobes, effective against anaerobes. So we will come across situations where more than one type of bacteria is causing an infection. So in such situations, to broaden the spectrum of activity, we use a combination of antibiotics. As seen in mixed infections, like we said, gram-positive, gram-negative, aerobe, anaerobe. And second situation where a combined use of antimicrobials is warranted is when we need to initiate treatment in severe infections. Because if treatment is not started immediately, the patient may die. We also need to use antimicrobial agents even in the absence of an infection. That is, prophylactic use of antimicrobials. Before an infection comes in, we prevent it. This is called prophylactic use. To prevent or suppress infections, as seen in against specific pathogens. For example, in rheumatic fever, HIV, tuberculosis and malaria. For example, in a household where there is a patient who is positive for tuberculosis, the other members of the family are given prophylactic anti-tubercular drugs. A patient with history of rheumatic fever is given prophylactic antibiotics, or a person from a non-malaria zone, if that person is entering a malaria endemic zone. For example, let's say a person from the United States is visiting India. So, before entering the endemic zone like India, the person needs to take prophylactic anti-malarial agents. Then second situation where antibiotics are prophylactically used are in high-risk patients. For example, in patients with valvular heart diseases who are undergoing dental extraction, or in patients who are undergoing anti-cancer therapy, or during mega-dose corticosteroid therapy, or in a patient who has undergone organ transplantation and is receiving immunosuppressants. These are all high-risk patients. Then prophylactic use of antibiotics is again used in surgeries, especially intra-abdominal surgeries. And in trauma, contaminated wounds. Now let's say a person meets with a road traffic accident, there are bruises, lacerations. Though the infection has not yet set in, the bacteria are already there in the victim's body. So to prevent them from causing an infection, prophylactic antibiotics are used. Many a time we come across an antibiotic not doing its job. That is, the antimicrobial agent has failed. Now why does this happen? It could be the wrong drug, the wrong dose, the wrong route or the wrong duration. So one needs to be familiar with the spectrum of activity of the antibiotics and also the susceptibility of the microorganisms to a particular antibiotic. Immunocompromised patients, the host defenses are weak. Elderly patients, weak host defenses. This could also contribute to failure of an antimicrobial agent. Then of course we have biological barriers. Now let's say there is an infection in the brain. Many of the antibiotics do not cross the blood-brain barrier. So the blood-brain barrier now has prevented the antibiotic from entering the brain. Now, there are many other factors. For example, if there is an abscess is a pus-filled cavity. If the pus is not drained, the antibiotic is not going to work. If there is a foreign body still present inside, the foreign body needs to be removed. Hyperglycemia, increased blood glucose is good nutrition for the bacteria to grow. So these factors need to be corrected along with the starting of an antimicrobial agent. Now coming to some of the sources of antibiotics, most of the antibiotics are obtained from fungi. For example, fungi and other bacteria. Bacitracin is obtained from this gram-positive Bacillus subtilis. Chlortetracycline and tetracycline are obtained from the Streptomyces species. Cephalothin is obtained from Cephalosporium fungus. Penicillium notatum is the source of penicillin. There are different methods by which antimicrobial agents can be classified. One possibility is based on the source, natural and synthetic and semi-synthetic. The other method of classifying will be based on the spectrum of activity, like effective against gram-positive organisms, effective against gram-negative organisms, effective against aerobes, effective against anaerobes, etc. Another method of classification could be based on the site of action, cell wall synthesis inhibitor, protein synthesis inhibitors. One more possibility of classifying is based on chemistry, beta-lactams, aminoglycosides, quinolones, etc. Like we said, based on susceptible organisms, narrow spectrum and broad spectrum. Based on the type of action, is it bactericidal or bacteriostatic? Based on the type of organism the drug is effective against, anthelmintic, antiviral, antifungal, antibacterial, etc. Based on chemical nature, like we said, beta-lactams, cephalosporins, quinolones, etc. Based on mechanism, DNA gyrase inhibitors, cell wall synthesis inhibitors, etc. Now coming to some of the examples, cell wall synthesis inhibitors, cell membrane permeability altering drugs, protein synthesis inhibiting drugs, drugs which cause misreading of the messenger RNA, drugs which inhibit synthesis of bacterial nucleic acids by inhibiting DNA gyrase synthesis or DNA synthesis or DNA function. And then we have antimetabolites, that is, these antimicrobials interfere with the formation of precursors of DNA and RNA. This table shows the spectrum of activity of antibiotics and other antimicrobial drugs. For example, here we have streptomycin, which is effective against mycobacteria and gram-negative bacteria. No activity against gram-positive chlamydia, fungi, etc. Tetracycline, which is a broad-spectrum antibiotic, is effective against gram-negative organisms and gram-positive organisms. Isoniazid has activity only against Mycobacterium tuberculosis, whereas ketoconazole is effective only against fungi. Acyclovir is effective only against viruses. Niclosamide is effective only against tapeworms. So from this table we can see that there is no antibiotic which is effective against all microbes, fungi, protozoa, helminths and viruses. Thank you.